Hello, my dear friends. Today we will discuss the topic shock. So, why do you want to learn about shock? Because shock is the most common cause of death in surgical patients. So, we see it in our ward, a lot of shock in our ward. So, what is the definition of shock? Shock is a systemic state of low tissue perfusion that is inadequate for normal cellular respiration. So there is low tissue perfusion due to decreased blood flow, and this blood flow is not adequate to maintain the functions of the cell. So that is shock. So how does the shock kill the patient? It can either kill rapidly due to the immediate effects or due to the insult of the shock slowly because of the consequences of organ ischemia and organ dysfunction. So how are we going to approach shock? We will discuss shock by pathophysiology, classification of shock, diagnosis and clinical features, treatment, and finally the clinical consequences of shock. So we will start off with the pathophysiology of shock. You know Hitler, right? Hitler, the problem in the Second World War started within Hitler's mind. It spread on to Germany, and finally it ended up in a world over war with Hiroshima and Nagasaki. So the same thing happens with shock. How? Shock can make problems in the cellular level in Hitler's mind, in microvascular level around small vessels around the cell, and in the systemic level like cardiovascular, respiratory, and renal. Now, what happens in the cellular level? Normally in the cellular level, there will be sufficient amount of oxygen and there will be aerobic metabolism, and enough ATP is produced, and carbon dioxide and water are the byproducts. But once there is shock, there is decreased blood supply, sufficient amount of sufficient amount of oxygen is not reaching the cell. So there will be anaerobic metabolism. And what is the problem with anaerobic metabolism? The amount of ATP is produced is less, and the byproduct is lactic acid. So once the amount of ATP produced by cell is less and the cell want more and more ATP, what happens? The ATP is produced less and glucose will get depleted. And once the glucose is also finished, the anaerobic respiration completely get stopped. And once the anaerobic respiration stops, what happens? The lysosomes in the cell will get activated and the lysosomal enzymes will destroy the cell. Once the cell destruction happens, all the lactic acid inside the cells comes out, all the potassium in the cell comes inside the cell comes out, and it affects the vessels and the cells around those cells. So that is where the microvascular level comes out. So it affects Germany. So all the potassium and lactic acid comes out, and in the cell, in the vessel level, there will be oxygen free radicals and cytokine release. Oxygen free radicals will produce the release of cytokine. There will be endothelial destruction, there will be immune system activation, and there will be coagulation cascade activation. So all these are happening in small vessels. So what happens in the level of organs? In heart, there will be increased sympathetic activity, tachycardia, hypotension, systemic vasoconstriction. In case of lung, there will be increased respiratory rate. And in case of kidney, there will be decreased renal perfusion and there will be decreased urine output. So all these are happening in the systemic levels. So cellular level, microvascular level, and systemic level. Now we will come to the classification of shock. What are the different types of shock? Different types of shock are hypovolemic shock, cardiogenic shock, obstructive shock, distributive shock, and endocrine shock or a mixed shock. Endocrine shock is a type of a mixed shock. Now, let us understand this diagram. This is the venous pool in the body. The blood reaches the right atrium by the great veins, superior vena cava, inferior vena cava. It goes into the right ventricle. Then it reaches through the right pulmonary artery, right ventricle, right pulmonary artery. It reaches the lung. From the lung, it comes and returns to the right pulmonary vein, reaches the left atria to the left ventricle, and finally again to the through the aorta into the cells, and then again into the venous pool. So this is the normal circulatory pattern. So what happens in hypovolemic shock? So first type of shock was hypovolemic shock. In hypovolemic shock, there is not enough blood here. So there is not enough blood to reach the circulation. There is not enough blood in the venous pool. So there is not enough blood to reach the circulation. So there is not enough blood to reach the tissue. So what are the causes of hypovolemic shock? What are the causes of hypovolemic shock? It can be either hemorrhagic cause or non-hemorrhagic causes. The hemorrhagic cause for hypovolemic shock is due to road traffic. Generally, we see road traffic accidents. There will be increased blood loss either internally or externally, and that is the cause for hemorrhagic shock. Now, coming to the non-hemorrhagic causes. So, either the blood completely can be lost, or there can be poor fluid intake, excessive fluid loss, or third spacing. So, coming to the poor fluid intake, the cause is dehydration, excessive fluid loss. It can be either through gastrointestinal system, vomiting and diarrhea, or through urinary loss in case of diabetes insipidus. Now, what is third spacing? So, the fluid is inside the body, but it is not in the intravascular compartment. So, where is the fluid? The fluid is around the point of inflammation. So, it can be either due to peritonitis, or it can be due to intestinal obstruction, or it can be due to pancreatitis. So, in peritonitis, all the fluid is inside. This is the peritonitis facies. So, all the fluid is inside the abdomen. All the fluid is inside the peritoneal cavity. In case of intestinal obstruction, the fluid is inside the intestinal lumen. In case of pancreatitis, it is around the pancreas. So, whenever there is inflammation, the fluid can be come to there, and it will not be available for the intravascular volume. So, that is third spacing. Now, coming to the cardiogenic shock. Coming to cardiogenic shock. So, here there is adequate blood volume in the intravascular compartment. But what is the problem? The heart is not functioning properly. The left ventricle is not functioning properly. It is not pushing the blood to the peripheral arterial system. What are the causes for cardiogenic shock? It can be either primary cause or secondary cause. Primary cause is the problem with the heart. Secondary cause, the heart is not working due to other causes. The primary causes are myocardial infarction, heart is not pumping, cardiac arrhythmia, the pulsation of heart is irregular, sometimes it stops, sometimes it works. Valvular heart disease, everything the heart pumps is coming back to the heart. Blunt myocardial injury, heart is not functioning properly. Or cardiomyopathy, the muscles of the heart are weak or it is not normal. So, all these primary cause of the heart can produce cardiogenic shock. Coming to the secondary causes. Secondary causes can be either endogenous or it can be exogenous. Exogenous cause, we sometimes hear celebrities dying of drug abuse. So, it is due to the suppression of heart by the drugs resulting in cardiogenic shock. That can be endogenous shock. Endogenous shock is due to the infections and sepsis where the toxins have a suppressive action on the heart. Next, we come to obstructive shock. In obstructive shock, there is again sufficient amount of blood volume. But this loop, the problem is in this loop where the blood goes from the right ventricle to the lung and back to the heart. There is some problem in this loop. So there are specific examples for obstructive shock. The causes of obstructive shock are cardiac tamponade, pulmonary thromboembolism, and tension pneumothorax. These are the most common causes for obstructive shock. Coming to cardiac tamponade. Here what happens is that there is collection of fluid in the pericardium. So the heart cannot expand. The right ventricle cannot expand. So there is inadequate pumping of the blood from the right ventricle. So this is a normal heart. We can see the fluid in the pericardium is compressing the right ventricle, causing cardiac tamponade. Next cause is pulmonary thromboembolism. What happens in pulmonary thromboembolism? Again, there is sufficient vascular volume. The blood is reaching heart, goes through the right pulmonary artery, and it is not reaching the lung. There is obstruction in the pulmonary artery. So that is happening in pulmonary thromboembolism. Where does this clot in pulmonary artery comes? It comes from it can be due to a deep venous thrombosis, peripherally DVT, and it can track through the great veins and reach the heart and then into the ventricle and then into the right pulmonary artery, causing obstruction of the pulmonary artery, resulting in pulmonary thromboembolism. When do we see this case? It is especially seen in post-operative patients. We come to tension pneumothorax. The third cause for obstructive shock. In tension pneumothorax, what happened? What is the difference between a normal open pneumothorax and tension pneumothorax? In open pneumothorax, suppose we stab the chest. The air, there can be lung injury and the air in the lung escapes out. And the air can go out of the chest and the air can go into the thoracic cavity. But what happens in tension pneumothorax? Suppose the patient is a chronic obstructive pulmonary disease and there are blebs in the lung and one of the bleb ruptures. There will be pneumothorax here and the air can come out of the lung, but there is no area for the air to escape. So the pressure inside the thoracic cavity will build up suddenly because there is no area for the air to escape. So that results in tension pneumothorax. What does the tension pneumothorax do? You see the air is inside the thoracic cavity, is compressing the lung, it is compressing the mediastinum, it is compressing the right ventricle. And what happens? The blood in the heart cannot be right ventricle cannot be pushed efficiently to the pulmonary artery, resulting in obstructive shock. So these are the different types of obstructive shock: cardiac tamponade, pulmonary thromboembolism, and tension pneumothorax. Now we come to the next type of shock, that is distributive shock. What do we see in the picture? In distributive shock, the vessel is abnormal. There will be vasodilatation both in all the circulations, both in the systemic and peripheral circulation, due to the circulating toxins or due to the absent nerve supply. There will be vascular dilatation. So there is sufficient amount of blood, but the blood will be remain there in the vessels and it will not reach the tissues. So that is the reason for distributive shock. The causes of distributive shock are: it can be either a neurogenic shock or it can be a septic shock. In septic shock, the toxins produced from the sepsis will reach the peripheral circulation, will reach the vessels, and it will cause vasodilatation. In case of neurogenic shock, there will be absent sympathetic activity, decreased sympathetic activity, and it will result in vasodilatation. The normal sympathetic activity is the reason for vasoconstriction. Now we come to the last type of shock, that is mixed shock, or it is generally seen in endocrine shock. Mixed shock means endocrine shock generally is a type of mixed shock. It is generally seen in adrenal insufficiency. So there will be a component of hypovolemia. There will be a component of distributive shock due to the decreased sympathetic supply. So these are the results. These are endocrine shock. So whatever the shock may be, there may be different components. It may be a combination of hypovolemic and cardiogenic shock, or it can be a combination of obstructive shock and cardiogenic shock. So say suppose it is sepsis. A patient with sepsis comes. The main component will be a distributive shock, but the toxins in the sepsis can cause depression of the heart, myocardial depression, and it can cause a cardiogenic component in that shock also. So Suppose when we are treating a shock, we should also see for other type of shock when we see a shock. We should not think that it will be only one type of shock. There can be components of these different types of shock. So how will we diagnose it? For that, we look for the diagnosis and clinical features of shock. Some of it we already know. Clinical presentation in heart, we know that there will be increased pulse rate and decreased blood pressure. There will be increased respiratory rate and there will be decreased urine output due to decreased renal perfusion. What will happen in blood? In blood, there will be lactic acidosis. In brain, there will be decreased consciousness level. So, these are the clinical presentation, clinical features. So, the patient may be in ICU. How will we detect? How will we detect these things? So in kidney, there will be decreased urine output. So normally the urine output it should be at least 1 ml per kg per hour, and less than 0.5 ml per kg per hour is an alarm that it is going and it is showing an impending renal failure. In heart, there will be tachycardia. We can see our multivara monitor. There can be tachycardia. There can be hypotension. When we look for the SpO2, it may be low and respiratory rate will be increased. So tachycardia, decreased BP and increased respiratory rate. Consciousness level, the GCS will be low. And this is the picture of ABG, and the pH in ABG will be low. There will be lactic acidosis. So these are the different types of shock can be classified as compensated shock, which is a mild shock, and an uncompensated shock, which is the moderate and severe shock. The shock can be classified as mild, moderate, and severe based on all these features: the blood level, lactic acidosis, based on the respiratory rate, heart, kidney, and brain. Don't try to study the table difficultly because everything increases. Lactic acidosis increase. Urine output decrease. Consciousness level decrease from drowsy to comatose. Respiratory rate will get increased and finally becomes labored. Pulse rate will get increased and blood pressure will get decreased. So based on common sense, we can write that in mild, moderate, and severe. Only thing is that there will be severe hypertension. One thing we have to remember: increased pulse rate will happen early, even in mild shock, and hypotension will only happen in severe shock. So, compensated shock, in case of hypovolemia, in case of a hemorrhagic shock, in the setting of a hemorrhagic shock, when we see that there is a compensated shock, it means around 50, there is less than 15% of the blood volume is lost. In uncompensated shock, it is 15 to 40%, and in severe shock, it is more than 40%. So when the hypotension to happen, severe hypotension to happen, there will be more than 40% blood loss. So in a normal 60 kg man, there will be 8% of his fluid will be 8% of his body weight will be blood. From that, we know that it is around 5 liters. So suppose it is 60 kg, it is around 5 liters. So 40% blood loss means there will be a 2-liter volume deficit. That will help us. This is not a perfect calculation, but this will help us to understand the amount of fluid we have to give. We have to get an approximate amount of fluid we have to give. So coming to the treatment of shock. Treatment of shock. What is the treatment of shock? Always in shock, think in terms of A, B, C, D, E. Airway, breathing, circulation, disability, exposure, and environment, in which we are more concentrated about the airway, breathing, and circulation. Disability, the GCS fall. Exposure or environment, we have to expose the patient fully, and we have to take away the patient from the environment causing the shock from the environment. What all will we look in airway? So suppose you are in outside and the patient is having shock when the patient is unconscious. We have to open up the airway. That is by the head tilt and chin lift. You have to tilt the head and you have to lift the chin. So head tilt and chin lift. If it is in a hospital setting, we can go for an endotracheal intubation. Coming to breathing. If you are outside, you can give a mouth-to-mouth respiration. If you are in a hospital setting, umbu bag respiration can be given. Coming to circulation, if we are outside and we are not feeling peripheral pulses, we can go for CPR. In a hospital setting, we can put wide bore cannula, infuse IV fluids, and everything fails, then we can go for a CPR. So we're doing all this. We are giving IV fluids. How much fluid will we go? We can give a 1 liter fluid initially in the first half hour. Then we can give the at the earliest 1 liter fluid should be given at the earliest by putting 2 wide bore cannulas. We have to put. When to stop resuscitation? Can we go on giving fluid like that? When to stop resuscitation? Again, that helps us depends upon the monitoring. We have to see whether the tachycardia is reducing. We have to see whether the BP is picking up. We have to see the conscious level is returning. We have to look for the urinary improvement of the urine output, and we have to look for the improvement in the acidosis. So that is the when to stop resuscitation will depend upon the normalization of this. Can all the patient be resuscitated? The patient is not improving on resuscitation, or the patient is deteriorating once you have stopped the resuscitation. So what does that mean? It means that the blood loss is continuing. It means the myocardial suppression may be continuing. It means there may be continuing tension pneumothorax. It means the sepsis is continuing, or it means there is a combination of these. So this is where the importance of diagnosis comes. So we have know the different types of shock. Whether it is we have to diagnose during the time of resuscitation, we have to diagnose whether it is due to hypovolemia, whether it is due to the cardiogenic shock, obstructive shock, distributive shock, or it is a mixed shock. Hypovolemic shock. So what will we do? We have resuscitated, but the patient is not improving. So initially we gave fluids. Next, what we can give? We can give blood. Again, the patient is not improving. We have to plug the blood loss. Wherever the blood is losing, inside the abdomen, inside the thorax, we have to stop the blood by surgically approaching it. That is the treatment of hypovolemic shock. We are resuscitating the patient, but the patient is not improving because the heart is not functioning. How will we make the heart function? We may have to either go for a cardioversion, or we may have to go for inotropic drugs. So that will depend upon the ECG, and we'll diagnose the cause for cardiogenic shock and we'll treat accordingly. Obstructive shock. How will we treat? For that, we have to know the diagnosis. In case of a cardiac tamponade, we have to remove the fluid from the pericardium. In case of a pulmonary thromboembolism, we have to remove the block either by approaching it endovascularly or by giving thrombolysis. In case of a tension pneumothorax, we have either put a needle thoracotomy or we can put a definitive intercostal drainage tube. What about distributive shock? In distributive shock, there is sepsis. So we have, and there is dilatation of the vessels. So we have to cause vasoconstriction. So vasopressin and drugs which cause vasoconstriction like noradrenaline and be given in case of a distributive shock. So we have resuscitated shock, and we have diagnosed the shock, and we have treated the shock. We have treated the problem. Is it like the patient will live happily ever after? No. The patient will not live, may not live happily ever after. It is good if once the patient is completely resuscitatable and the patient comes back, it is good. But there are clinical consequences for shock. So what are the different clinical consequences of shock? It can be either an unresuscitatable shock, it can be systemic inflammatory response syndrome or ischemia reperfusion syndrome, or it can be a multi-organ dysfunction syndrome. All the patient will not survive. Unresuscitatable shock. Whatever we do, we cannot bring back the patient immediately. The patient deteriorates. That is unresuscitatable shock. Here the patient dies rapidly. Now, systemic inflammatory response syndrome or ischemia reperfusion syndrome. What happens? Normally, the atmosphere around the tissue is atmosphere around the cell is peaceful. All there is adequate tissue perfusion. The blood is reaching all the tissues, all the organ systems. In shock, what happens? There is decreased blood supply to all the tissues and cell. So what happens? There will be acidosis among the tissue level or among in the cell or around the cell. So then what happens? We are resuscitating the patient. Blood is reaching everywhere, but during this time, this acidotic part will go into the blood. So once it reaches the blood, it will make problems for the organ, and there can be slow dysfunction of the organ. So during the time of shock, the patient may be good. All the organs in the patient is functioning properly. But after resuscitation, the patient will get bad. That is ischemia reperfusion syndrome. So this generally happens in case of a limb injury. There can be prolonged ischemia to the limb, and once we give fluid and improve the patient from shock, the accumulated toxins from the limb can reach the systemic circulation and cause renal failure and multi-organ dysfunction. So this is a classical picture of ischemia reperfusion syndrome. Once the toxins in the blood are reaching the tissue are reaching the blood, we can see the systemic inflammatory response syndrome. Systemic inflammatory response syndrome include tachycardia, tachypnea, and increased leukocyte count. Now comes the multi-organ dysfunction syndrome. During the shock, due to the decreased perfusion, the organs are already damaged. Some amount of damage happened to the organ. We have given blood supply, we have given enough fluid and blood, and all the organs are again all the organs are supplied with blood, or there is enough perfusion for all the organs during resuscitation, after resuscitation. But the injury during the time of shock in these organs will not improve, and the patient will slowly die or succumb to multi-organ dysfunction syndrome. It is like the radioactivity, the Hiroshima, we have learned about Hiroshima and Nagasaki, the Hitler's mind reaching in, finally resulting in Hiroshima and Nagasaki. After the Hiroshima and Nagasaki, the systemic insult, many of the problems will not get improved. So, like that is multi-organ dysfunction syndrome and ischemia reperfusion is like that. Even after the insult, even after the attack, the insult for the organs remain. So we understood how the problem in the mind of Hitler, spread into whole of Germany, then to the whole of the world, and finally resulting in Hiroshima and Nagasaki. And even after that, the problems are still remaining. The problems in the shock start from the cellular level to the microvascular level to the systemic level, and even after resuscitation, there can be problems in the organs. So we have discussed about the pathophysiology of shock, cellular, microvascular, systemic, the different types of shock, hypovolemic shock, cardiogenic shock, obstructive shock, distributed shock, and mixed shock. Endocrine shock is one example. Then diagnosis and clinical features, the mild, moderate, and severe shock, the compensated and uncompensated shock. The treatment of shock include the resuscitation, ABCD, monitoring, when to stop the resuscitation, and the definitive treatment of shock based on the type of shock. And the clinical consequences of shock. Everything is not happily ever after. There can be unresuscitatable shock, ischemia reperfusion, and multi-organ dysfunction syndrome. So that is regarding shock, my dear friends. Thank you.